Hello, I'm Kathy Trotter, nurse practitioner and assistant professor at Duke University. This video will be a short clip about group medical visits, and in particular a concern as this innovation grows and becomes a very strong model in our healthcare system about its lack of a reimbursement code that's appropriate for it. This model is very interesting in showing early evidence that it will make a difference in outcomes, patient satisfaction, and healthcare utilization. But first, let's talk a little bit about the model and show you what it looks like.
Marcia Johnson, the younger sister.
Sharon Jones, her sister.
And they share more than genes. They also share doctor visits. They're participating in what is called a shared medical appointment with 6 other women who are concerned about their heart health.
I ended up having to have surgery. I had 2 stents and 1 below procedure.
More women than men have died from heart disease every year since 1984.
This is part of the reason why Dr. Amy Tucker, cardiologist at the University of Virginia Health System, began offering shared medical appointments. The reasons why these women are here are as diverse as their group.
So at a routine doctor visit where I get my blood pressure medication, it's like, okay, let's check the cholesterol. So I was quite surprised to find that it was much more elevated than I was expecting. So then it was like, where can I get more information about this? What can I do to lower it? Where can I learn about risk factors? So this was the perfect place for that.
Treating lifestyle, empowering women to develop heart-healthy habits around nutrition and exercise and chronic disease management such as diabetes and weight loss, that is a much different process.
It's a process that requires a different kind of approach. These 90-minute appointments include a check on vital signs as well as visits with doctors, nurses, nurse practitioners, dietitians, and even an exercise physiologist.
I'd like to explain the model to you. These visits occur when several patients, average 8 to 20, usually with a similar health condition such as diabetes or pregnancy or asthma or well child visits, come to their medical clinic for a group appointment to see their clinician. They spend 90 minutes to 2 hours with their clinician and receive group education, support, and individualized medical care during the visit. Early evidence shows patients have high satisfaction with the model, have decreased emergency room usage, and health outcomes are improved, particularly studied in prenatal care, with significant decreased preterm delivery rate by 4%. And diabetes has shown better control. So I provide this type of medical care on a weekly basis, and many other primary clinicians as well as specialists also provide this care. The Agency for Healthcare Research and Quality, as well as the Institute for Healthcare Innovation, both support the model's growth due to the potential for high quality care it can offer. However, for this innovation to be adapted, it needs appropriate reimbursement, and this is currently lacking. Specifically, there is no CMS reimbursement code for provider-attended group visits, and this needs to be addressed. I recently spoke to Greg Griggs, the Executive Vice President of the North Carolina Academy of Family Physicians, and he has similar concerns. Let's hear what he has to say.
We have many of our members are now using group medical appointments as a way to supplement the regular care they give. And one of the issues is it's not very clear how to get reimbursed for such a service, and especially under Medicare regulations. And so, and even with private insurance. So with private insurance, they have to really make sure and go ask the insurance company, how do you appropriately bill for it? And one of the things that could simplify it is to have a separate CPT code for billing a group visit. Our national association, the American Academy of Family Physicians, has contacted CMS to try to get clarification on how to bill for it, but there's still not an exact way to do it to simplify the process. And it does make it more difficult. You know, in this tough economic environment, you need to be paid for services, and our whole system of fee-for-service payment may not be the most effective payment system. And CMS is looking at a lot of other ways to paying for value. Until we get that really system of what we value changed, it would be very beneficial to have a very specific way to bill for a group visit.
How is it currently billed? If a group visit clinic has 10 patients in 2 to 2.5 hours, this equals an average of $410 billed. A likely reimbursement rate of 58% then nets $237. This sounds reasonable, except that this model requires increased provider experience and facilitation skills not normally received in training programs, and it requires attendance to workshops or other training to learn these enhanced skills. Also, an assistant to co-facilitate and assist with the process is necessary. Clinic overhead is not necessarily reduced in the model, but efficiency is improved. Since the CMS initiative includes reimbursement based on quality of care provided, and early evidence indicates improved outcomes with significant potential savings in medical care, such as Medicaid and Medicare costs, then the reimbursement should be higher than regular care. The solution is to review the data and assign an appropriate reimbursement code for provider-attended group visits.